All right, everyone, welcome back to Pulm Peeps. For those of you following our guideline series, we've been going through the GINA 2024 guidelines, breaking them down into smaller aliquots and discussing how we can actually implement these guidelines with our patients that we're seeing in the inpatient setting as well as in our outpatient clinics. In episode 1, we talked about the diagnosis, phenotyping, and assessment of asthma. In episode 2, we talked through the treatment and management of asthma. In episode 3, we covered all things biologics, where we were joined by Megan Conroy as our guest. And today we're bringing you the final episode of our asthma series, where we'll discuss some evolving areas of asthma management, as well as go through some clinical applications of asthma management in case-based format. And of course, we got our Pulm Peeps guideline crew, Rupali Sood and Tom DiAntonio, here to break things down. Rupali, Tom, ready for another deep dive?
Excited to be here, Monty. We're happy to be back in the studio recording again, and very excited for our episode today with our very special guest.
Yes, I echo what Rupali said. Excited to be back. Looking forward to today.
Perfect. Excited to see you as always. Thrilled to introduce our guest today, who is making her Pulm Peeps debut, with Dr. Meredith McCormack joining us for our guest expert today. Meredith is a professor of medicine at Johns Hopkins, where she leads multiple NIH-funded endeavors at really trying to understand lung health and disease. She's our division director for pulmonary and critical care medicine, while she also directs the Asthma Precision Medicine Center of Excellence, as well as the BREEZE Center, which focuses on understanding the effects of the environment on lung health and disease through research and community engagement. Meredith is an internationally recognized expert in asthma management, dedicated member of the faculty who's spending some time today because she has a great commitment and investment in early career faculty as well as trainees. We're excited to learn with her today on some advanced topics in our Capstone Asthma Guideline series. Meredith, welcome to the show.
Thanks, Monty. I'm excited to be here. I'm a big Pulm Peeps fan, so thanks for having me.
Love that. I know you can't fill the void of Dave, but I feel like you're going to come close to it. But I will say, for those listening, as I mentioned on the prior episode, Burf is one of the biggest Bills fans I know. Meredith is one of the biggest Eagles fans I know. So we could have had some great banter today, but we'll go ahead and get started. As our quick disclaimer, this podcast is not meant for medical advice. Our opinions are our own and do not reflect our employers, and the cases referenced today are HIPAA compliant with some details that may have been changed to protect the identity of our patients. Let's get started. Today, we're going to cover 3 big areas. The first one that we're going to cover is asthma and comorbidities, with really a focus on how obesity and GLP-1 receptor agonists have been recently studied and could be a new avenue for the future. We'll talk about dual biologic therapy, the when, the why, and the how. Our third theme is de-escalating inhalers. When can we safely step down therapy in patients who are on biologics? And we'll end today with any final pearls from Meredith's vast experience. So I'm ready to get into it. Rupali, what about you?
Yes, so excited, Monty, to get started today. Let's start off with something we're seeing more in clinical practice, and that's obesity-related asthma. We all know that obesity can affect lung mechanics, airway inflammation, and even how our patients respond to the therapies. But now we've got new kids on the block. We've got our GLP-1 receptor agonists, and these medicines have also been, and there's newer and newer research to show that they might also benefit in asthma control. They've been game changers in metabolic disease, but there may be other benefits. Meredith, can you walk us through a case where obesity was a key factor in asthma control, as well as how you approached it and thought about these newer medications?
Sure. The use of GLP-1 agonists is something that has been brought to light for me in the care of my own patients. And there's one patient that comes to mind who actually is one of the first patients I started on biologic therapy. This patient had actually been in a clinical trial and had this really remarkable benefit from being on biologic therapy in the trial. And then as soon as this was available clinically, and I started her, in this case, in mepolizumab, and she again had a sustained benefit. But this really improved her life substantially. She got off steroids. She had lost some weight. In her work life, she stopped missing so much work. This improved her relationships at work, her productivity. She had a lot of pride in that area. In general, her well-being and ability to function and exercise improved. As I cared for her over time, her visits with me actually decreased in frequency because she wasn't needing as much frequent asthma care. but she kept her appointments and we followed over time. And in the last year, she had an appointment. And when I walked in the room, she had clearly lost a significant amount of weight. And she was talking about some of the new things she was doing. She was more engaged with grandchildren, was just feeling a lot better. And I asked her if she thought that the weight loss and the GLP-1 medication had improved her breathing. And she had a resounding yes, that she felt like she had gotten this step up with biologic therapy, but then a whole other step up when she started her GLP-1 agonist. So it's just an N of one in her case, but I really thought it underscored the potential for this class of medications to really provide benefit for our patients with asthma.
That is a really fascinating case. Thank you for sharing. It makes pathophysiologic sense, too, that there is this inflammatory component related to obesity. And as far as I understand, Meredith, there are some trials that are ongoing right now looking at GLP-1s and other ways of modifying metabolic health and as a way of modifying asthma outcomes.
Yes, personally, I'm so interested in the overlap between obesity, metabolic dysfunction, and asthma, and think that this is really going to be our next frontier in asthma management. There's been a lot of focus on allergic and T2 inflammatory pathways, and we've seen amazing advances with the biologic therapies in this area. In addition to GLP-1 agonists, we have a lot of interest in metformin as a potential treatment for asthma, as well as the newer agents. And these could act on multiple different pathways. I think one of the things we'll learn through trials and other studies is the potential benefit of these medications, as well as how they're acting and what pathways are really being engaged in improving asthma. There are colleagues that are leading these efforts. David Wu at Baylor, he and I are collaborating on a metformin pilot trial with a goal of designing a larger study. And Katie Cahill at Vanderbilt has been on the forefront of leading work in GLP-1 agonists. I'm excited to see where these efforts lead.
It sounds like this is potentially some of the new frontier for us in the management of asthma. I think it's going to be something we're going to see more and more publications and research in coming years. With all this new information that we're gathering on the relationship between metabolic health and asthma health, how have these things changed your approach to asthma management in patients such as your own?
When I think about obesity or metabolic dysfunction in my own patients, even for a long time, I've counseled on weight loss, really trying to encourage formal weight loss programs when possible, increasing physical activity. Now we have even more potential tools to offer our patients, potential opportunities for therapies. And so now I think I'm more mindful of trying to be direct and explicit about talking about obesity or diabetes or prediabetes, and pointing out that there are new medications that have been transformative. When those are possible options for my patients, I want to make sure that I'm referring them back to their primary care, their other subspecialists who might be able to help partner in getting these therapies to the patient.
Thank you so much for sharing, Meredith. And you brought up a couple of things I definitely wanted to comment on. First, I think great to highlight some early career faculty with David Wu and Katie Cahill. I remember David and I were co-fellows together, and when he first started talking about metformin and asthma, and now this was some time ago, but I was like, David, really? Metformin? Where are you going to go with that? And look at you now. So that's just great, taking it from an idea he has as a fellow, now as a transitioning to early career to mid-career faculty member. Meredith, you alluded to some of this. I remember you and I were at a recent grand rounds where they were talking about GLP-1 in a different population. How do you think moving forward we can partner in a multidisciplinary team involving primary care physicians as well as pulmonary critical care physicians? But interested if you had any other thoughts on that space right now.
This week, I was meeting with Jonathan Jun and Lou in our division because they have a lot of interest in sleep medicine. I think that's another area, especially in pulmonary critical care, where our sleep partners are asking interesting questions and thinking about how these medications might apply in that field. Just to your point, I think keeping an eye out for those potential collaborations, both clinically and from a research standpoint. I think partnering with our endocrine colleagues who are studying this in diabetes, I love to think about ways we can add on or think more deeply about our patients that live at the intersection of multiple chronic diseases.
Awesome. Thank you for sharing. I think definitely a space to keep watching, and excited to see, patient implementation, new research collaborations. This was, I think, a great first case to highlight, but I want to move on to another complex scenario. And this is one where a patient with asthma who might actually benefit or have been put on dual biologic therapy.
This has been such a great and formative discussion focusing on metabolic health. But now let's switch to thinking a little bit more about a different patient scenario. Let's say we have a patient, we have biologics targeting upstream targets of TSLP, and we have downstream biologic targets, IL-3, 4, 5, and IgE. And as we discussed in our previous episodes, we're getting better and better at phenotyping severe asthma. Meredith, we are curious about patients who may need to switch biologic therapies or may benefit from dual biologic therapies. Can you tell us a little bit more about how you think about this and maybe describe some specific patient cases in which this has been applicable?
Sure. When I'm thinking about the possibility of dual biologics or switching biologics, it's really the case where we haven't achieved or sustained adequate asthma control biologic therapy. I had a patient over the last year where this was the case. She is one of my earliest patients that I started on biologics. She's done very well over a number of years, but this year had a series of exacerbations. So she was treated with prednisone and didn't have a full response. And we used another course of prednisone and then a taper. And so she seemed to be falling into a cycle of recurrent or refractory exacerbations. The trigger was likely viral, but it wasn't really clear. I started to wonder about whether this was a prolonged treatment failure or she would benefit from alternative therapy. I thought about adding another biologic agent. So she was on an anti-IL-5, and I thought about maybe adding an anti-IL-4/13 like dupilumab. In her instance, actually, I ended up switching her from an IL-5 to an anti-TSLP agent, tezepelumab, really with the idea of maybe going to a more upstream target. In this patient, she also has elevated IgE, so the tezepelumab potentially has an impact in that way as well. But I think these are really complex decisions and often are really important to engage the patient. So I think it's a great area to highlight patient-engaged decision-making. It is just challenging to try to disentangle whether after a period of years, you would just expect someone to have intermittent exacerbations every once in a while. She's clearly done much better than she would have been doing off of biologic, but it's hard to predict the future. So I think it would have also been reasonable for her to, with her engagement, to decide that we were just going to stay on the same treatment and watch. I think there's a lot of nuance to these types of decisions, but understanding the different pathways can be helpful. In this case, we opted for moving upstream to see if we could gain better control over the next period of time for her.
That's a really fascinating case. And I like how you highlighted the way we as asthma providers have to understand the biological mechanisms that underpin all of this and how it's really enhanced the way we can manage the care of these patients. This case you described is a pretty tricky one. There's not a lot of evidence-based guidelines. Meredith, how do you think about which patient you would start on dual biologic? And what's your thought process in when you use one over another?
Yeah, I think just in biologic selection, especially for a while, we had biologics that were available for patients who had eosinophilic severe asthma. There are a lot of similarity, or can be, in their profile in terms of their end-typic markers like peripheral eosinophilia and fractional exhaled nitric oxide. And so sometimes that can be not as discriminating. One area I think can be helpful is thinking about comorbidities, because we do have biologic therapies available for dual indications. One that's pretty frequent in my clinic is chronic sinusitis or nasal polyposis. I have several patients who have that condition, and then their biologic therapy, they have pronounced improvement in upper airway symptoms as well. I have several patients who have regained their sense of smell, and that can be life-changing. Someone who can now smell consistently, and that influences your sense of taste. So that's really exciting when that benefit is part of the response. Other patients, I have some patients that have had improvement in atopic dermatitis, and that's been really also very satisfying and life-changing for those patients. So thinking about comorbidities and whether you have a co-benefit of biologic therapy can help guide specific choices when there's not otherwise a clear preferred medication.
And that's so great. I think one of the things also, Meredith, we come across with our patient in these biologics is that they are injectables. And so some patients talk about how that can be a barrier and can make this a difficult medication for them to access. Just wondering your thoughts on the conversations you have with patients regarding these discussions and how that plays into your thought process about biologics and advanced asthma therapies.
Thank you for bringing that up. Appreciating my patients' interaction with needles is something I really learned from my experience with biologic therapy. And just a couple examples. One of my patients, we had talked a lot about biologics. We had gotten the medication available through her insurance. And I was excited to see her 3 months after we had started. And I came in ready to hear about her response. I was enthusiastic, anticipating she would have a nice clinical response. And I could tell when I asked, her face dropped. And I didn't really start it yet. And I had just underappreciated the barrier for her of learning and being able to do those injections. And that's actually something that became more apparent when the home medications were available, because we started doing this in clinic. And then I think that's less of a barrier. I think generally patients felt less onerous to come in and have someone else administer the shot. I'm much more cognizant, and I think could do a better job of communicating around that. I haven't had any patients who haven't been able to figure out a way to do self-injection. Either they do it themselves or have a family member. Different patients have different levels of discomfort or distaste for the idea of having an injection. And I still have some patients who say they have to really steel themselves for that day and that moment. So I think just appreciating that this is part of the patient experience and talking about it, making sure we don't forget that that really can mean different things. Some people, it's not a big deal at all. And other people, it really is something they have to buy into and find a process that works for them.
Thanks, Meredith, for bringing that up. An important and humbling reminder that we can order all of the medications in the world, but we have to really understand if our patients are taking them, and if they're not, try to understand barriers. Meredith, we briefly talked about this in our last episode on biologic therapy when Megan Conroy joined us, and there's different types of biologics and different frequency of administration. And I'm wondering if you've encountered instances in clinic where patients may have needle phobia or issues with administering the injections themselves. Does that play into which biologic you may want to order?
It certainly can. And for patients that have needle phobia or are dreading those injections, thinking about which biologics may allow them a little bit more of a reprieve. For example, pembrolizumab starts monthly, but then it moves to every 8 weeks. So that can really be a difference for someone versus dupilumab, which is every 2 weeks. Over the course of a year, that can make a difference. So I do think about those features and making a comprehensive decision.
That's a great framework to think about and for us to keep in mind as we're ordering these things or referring patients to specialists that can help with that biologic initiation. And I want to relate it, but just extend on this a little bit further, Meredith. And so let's say a patient does really well in biologic therapy. At what point do we start to think about de-escalating the inhaler regimen?
Yeah, and I think once we're chatting about, a lot of times this comes up in our clinics, right? Now we are having more and more asthma patients come back after starting their biologics. They've been stable on it for a few months or even a year. And so why don't we take a situation like this? A patient has been stable on a biologic for a year, telling you they have minimal exacerbations, and is requesting, doctor, what can I do next? How can I reduce my medication burden, my inhaler burden? We generally end up discussing decreasing the ICS dose portion. We've talked about that in our prior podcasts as well, stepping down from high, medium, low, but then we're left with where to go. I know we've also talked about, should we take off other therapies, the add-ons, the LAMAs, the leukotriene medications. Meredith, really curious to know, when you think about step-down therapy, since there are no clear guidelines in this realm, how do you think about this with your patients and approach it?
That's a really important topic. I think I learned the biggest lesson from one of my first patients. It had started on a biologic, and this is when the biologics were, again, being injected in clinic, so they weren't available for home use quite yet. But I had seen her frequently because she was requiring a lot of prednisone and had frequent exacerbation. And then after she started biologic therapy, I hadn't heard from her in a while until a few months in, she was in the emergency room for a really significant asthma exacerbation. She had broken her leg and hadn't been able to manage the logistics of getting into clinic for her injections and had stopped her biologic. But in the meantime, she had not refilled any of her prescriptions and she didn't have any of our other medicines at home. She really ran it in trouble with a significant asthma attack. What that taught me was that at the outset of starting biologic therapy, I start talking about step down. And what I do is I ask my patients to commit to staying on their current medication regimen for at least 3 months until we check in. And I tell them that I hope that they're going to experience a significant benefit, but to really quantify that benefit and understand it, I want them to stay on their other medicines so we can really understand what's the contribution of the new medicine to the benefit that we hope they get. At that visit, I also discuss the strategy I think we'll employ if we are going to step down, in part because sometimes people will go ahead and step down on their own. And so I want them to maybe then anticipate what we would do. And for me, I think about antihistamines and the leukotriene modifiers. I usually plan to pull those off first. This is a customized decision for every patient, but generally I think about those categories. If they're on a combination ICS LABA, I want them to stay on that. And that would be among the last thing that we would be pulling off depending on what the person's medication regimen is. But I start those conversations early and I try to put out a scaffolding of a plan so that the patient knows how important it is not to just stop all of their medications.
I love how it's such a personalized decision. And I think it really highlights something that we've seen over and over again in this guideline series. What the GINA guidelines emphasize is that while we have global level guidelines, we have to apply these to individual patients and collaborate with our patients and understand what their goals are for therapy. And I think that really highlights exactly what you were talking about. When you are thinking about stepping down therapy on a patient, fortunately, someone's gotten better with their biologic therapy. They're not needing steroids anymore. Are there any particular biomarkers you look at or other clinical indicators you use when making that decision?
I talk to patients and think about the goal of having normal lung function and being symptom-free. That's daytime symptoms, nighttime symptoms, as well as thinking about the context of exercise or physical activity. And not in some patients, normal lung function may not be an achievable goal if they have chronic fixed obstruction over time. But generally, I think about those two things and then use inflammatory markers as well, like peripheral eosinophils are one example. We don't actually test FeNO typically in our clinic, but that is another biomarker that would be very reasonable and might provide some insight.
This is such a great discussion. We've talked about when we think about adding on biologics, and now we're talking about how we can de-escalate therapy when patients are starting on biologics and have been stable for some time. I'm curious, though, in your practice, if you've ever also encountered patients who you started on a biologic therapy, but maybe haven't benefited in the way that you expected them to benefit. And then how do you think about that biologic therapy? Should it be continued? Should it be discontinued? Where do we go from there?
Yeah, that's a really good question. I would think about revisiting the totality of the diagnosis as well as the drivers of the disease course and therapies. One is making sure adherence to the whole medical regimen as inhalers as well as biologics, because that's important. Biomarkers can help as well. If you're expecting to have a dramatic decrease, for example, in peripheral eosinophils, that would be important to check. Also revisiting the diagnosis. In my clinic, I have a severe asthma clinic, and sometimes vocal cord dysfunction or irritable larynx can be playing a role, or upper airway. So making sure to revisit all the different contributors that can present with an asthma-like picture is, I think, an important step in that of reevaluation. And then, for example, like the patient I took before, maybe think about advancing to an upstream target. If someone on an anti-IL-5 or IL-13, that's where I might go to an anti-TSLP to think about maybe the inflammatory cascade has other targets that could be hit by more upstream medication.
Thank you so much, Meredith, for sharing that. I think what you've really just shared with us, and a humbling experience, our patient taking the medications. I think the continued need for reassessment of our patients, how they're taking their medications. Do we have the right diagnosis? This brings up the question that we need to have a whole episode on asthma mimics or polytoms. I think we could start thinking about that as another potential episode. But just really love the approach so far that you've provided, Meredith, and such a great framework for us to move forward with.
Yeah, and Meredith, I think we've covered a lot of ground here today, from metabolic disease to thinking about dual biologics to step-down therapy. But just for our listeners and some key takeaways, would you mind sharing maybe 3 top pearls for managing complex asthma cases?
Yes, I think the number one thing, and if you have been in my clinic or heard me talk about asthma before, my favorite thing is to talk to my patients about their medications using a visual aid. And my favorite one is from the Asthma and Allergy Network. If you Google Asthma and Allergy Network and inhalers, you can find it really easily. It's a pictogram that shows all of the inhalers that are on the market. And I use this to ask my patients in an open-ended way what they're taking. And that starts a conversation. It's very efficient. So that's my number one, is always talk to patients about what they're actually taking and how they're taking their meds. Number 2 would be to think about biologic therapy for patients that are requiring steroids or not having completely controlled asthma, because I think these medications are really transformative in the right population. And then third, going back to where we started today, thinking about metabolic targets and obesity. And now that we have this really transformative class of medications, thinking about whether those are appropriate for our patients now for indications that they may have, and also looking to the future to see whether they may have specific indications for the treatment of asthma.
I love it. I think one of my big takeaways from this is that we really need to think about our patients on an individual level, think about their comorbidities that are affecting them, and then use that to tailor and personalize our approach. In addition to looking at the GINA guidelines, reading textbooks, going on up to date, Meredith, do you have any other recommendations on where folks listening can go and learn more about this, enhance their own knowledge?
Other resources that I like to point to or use myself, the American Lung Association has a great webpage that has patient-facing materials, public-facing materials, and print and video. So that's a great resource. And I'd be remiss if I didn't mention our own website, breathecenter.org. We have a lot of information there, in particular about environmental drivers of asthma. And those are 2 places I like to point to.
Yeah, definitely some fantastic resources for us all to use. And thank you for noting those. I think we've had a really great discussion over this last 30 minutes, highlighting 3 different cases that you may be presented with at some point along their care, and how you can either provide and implement medications and treatment yourself, or find a referring pulmonary critical care medicine specialist that can help you. Thank you again for joining us, Meredith, and thank you for our listeners. If you've enjoyed this episode, be sure to check out our full asthma case series on Pulm Peeps. This is our 4th and final episode of the Asthma Guideline series. This script was written by Rupali and Tom D'Antonio and edited by myself and Dave Faro, and original music is by Eric Rogers. And we'll see you all next time.
Thanks, guys. That was fun.
That was great.
That's great.